I want to thank Elaine and Bob for those great and interesting presentations that we've heard about training of our nurses and our doctors. At this time, I know that we stand between you and the 30 minutes for lunch. So I have a couple of questions for the speakers, and then we'll begin with the roundtable members, and time permitting, we'll open the floor. So my question for both of you, in light of everything that we heard Diane talk about in the keynote speech, talking about how health literacy is our problem as clinicians, doctors, nurses, whoever we are. And we heard Bob talk about this culture change. I want to know how we are preparing the next generation in really doing what they do. We heard doing what we do is cure, not that doing what we do is communication, or doing what we do is transition of hope. So I was hoping if you could both speak to that.
I'll go first. I have so much energy. I kind of disagree with Bob that I'm not dismayed this morning. I am just fired up to go back and do more work and work harder because there's just so much to do. I think it's an incredibly exciting time for palliative care communication researchers and for anybody in palliative care. For 15 years, we've had pioneers saying, we need palliative care, we need palliative care, and we've had wonderful evidence of that this morning. Now it's time for the communication side to really be highlighted. And so it's not just so much that we need palliative care and we need to have a talk, but the exciting thing in the next 15 years is that what does that talk look like? What does it need to look like? Does it need to be standardized or structured? What are the components of it? We heard about the wonderful serious illness conversation guide project. That's the beginning of this shift to looking at the content of what is said and how it's said. And I think that's the most exciting part. The challenge is then developing those tools. Tom talked about decision aids and question prompt lists. We are in its infancy in developing tools in any area. I mean, some specific disease areas have already worked in developing those tools, but from a palliative care perspective, we don't have palliative care decision aids per se. We have a lot of in oncology, and we don't have question prompt lists that we could provide patients and caregivers that would then help us have conversations with them. So I think that the next step is really some quality research on the communication strategies that are then going to be used to train providers across the board. And I'd go even further to say we really need to prioritize interprofessional education as a key component. This is not the oncologist or the palliative care physician's responsibility to ensure that what they say to a patient and family member is at the appropriate health literacy level. It is the entire team's responsibility, and there's a team process part of it that has to be accounted for when we think about training providers in communication. Okay, I'm going to shut up.
I'm a lot closer to being a frail elderly than Elaine is, so maybe that's why I'm more tired. Look, I think medical schools are doing a lot more to teach communication skills. Vital Talk is working with, in fact, now heart failure doctors and nephrologists and neonatologists, and we had someone's doing a course for pediatric cardiologists. There are lots of courses that are starting. It seems to me the two big challenges are, one, after they're taught how to do it, are they going to be deposited in an environment which gives them positive doobies for doing it? Or are they going to go in an environment in which a 10-minute conversation is 5 minutes too long because they have so many other things to do that the healthcare system tells them that are more important than communication? And the second thing is that we need to be careful that we don't just add more cognitive material, because most of us don't make decisions based on facts. You didn't choose your spouse based on facts. You didn't choose your house totally based on facts. You chose your car because you walked into the car dealer and you said, ooh, I want one like that. Now, some of you, the engineers among you, probably did all the positives and the negatives and the long list, but the people in the marketing world get that we make decisions based on emotions. And if you go to the psychologists these days, they all talk about emotional intelligence and how emotions change values and change how we weigh decision making. And we need to think about what will it be to help clinicians have the emotional resiliency to have these conversations that are really hard and are really sad. However you cut it, they're really sad.
I think that's an excellent point when you mentioned emotional resiliency. So my follow-up question before we go to the roundtable is that we know that when we're talking about patient health literacy, we expect that to improve. So what are your expectations, given that we're no longer going to train in silos? We're going to take the benefit of the nurses receiving the information and physicians initiating the information. What are your hopes for improving health literacy among us?
So it's interesting because I think the interprofessional communication piece is really good. We don't have any idea how to do it. Let's be honest. We have no idea how to build a good band. We don't even know how to make sure that the doctors and the nurses have good communication skills. That is, they can play the trombone and the drum. How to put them together so that they don't conflict with each other and that they're resilient. And in particularly in our healthcare system where the same doctor never works with the same nurse. We treat each other as widgets. So on the hospital ward, there's a different nurse every 3 days. There are different doctors every week. When we talk about interprofessional, we sort of basically view that we have no idea. It would be like every week having a different band because you took kids from different schools and you put them together and you expected them to play well. We don't know how to do it yet. I think there are lots of opportunities, but we ought to be really clear that one of the things is we need to figure out what are systems that will work better for patients, and then how can we make the healthcare system match that? I don't have a solution. Maybe because I need lunch.
Elaine?
I agree, Bob. I need lunch too. One of the things that we put together for our hospital-based palliative care team training is that we realize that the palliative care is a team that stays pretty constant. And so what we wanted to do was teach those palliative care team members to use the same language when communicating with patients and families. If you have everybody using the same language and everybody's practicing what we call the same team-based communication approaches, then that's what's going to initiate some cultural change at your institution. It's also going to help patients and families when they hear the same message or the same language from the palliative care social worker as they do from the palliative care nurse, as they do from the palliative care physician. And so in terms of literacy training, we encourage our palliative care teams to meet together to come up with a unified definition or explanation for palliative care that is specific to the patient population that they are serving. And so we encourage them to come up with a metaphor that maybe represents something that's very culturally specific to the geographic location that they're working in. We also encourage them to come up with different ways of explaining some of the common terms that they explain as a team. Because if they begin to hear the same message, then they're not getting conflicting messages from just even the palliative care team, but when other members in the healthcare institution come in to see them, they're going to say, oh, well, the other doctor that was just in here said this way. And if we have all patients and families in one institution saying, oh, well, the other doctor that was just in here said it this way, then we're all going to be part of a cultural shift into using some of the same language. Now, and there is no right or wrong language choice. We advocate that that has to be specific to the patient population and the geographic region that you serve. There's not a definition or a metaphor I can come up with that I can hand off to somebody and say, use that at your institution across the other side on the West Coast or the East Coast. As it has to be culturally specific in order for it to be effective.
Thank you. It's a great point. I'd like to open up to our roundtable members for any questions that they might have.
Yes. Yes, do you have a question?
Oh, okay.
Thank you. My name is Winston Wang. I'm a member of the Roundtable. And you touched upon this in your comments with regards to interdisciplinary training around communication and palliative care. But you talked about it relative to, I think, for clinicians, nurses that are already in practice. Do you know of, or would you recommend some aspect of really being trained, a curriculum development aspect of this, in terms of nursing school, medical school, et cetera?
Is that to me? Oh, okay.
Both of you, I think you both touched it.
Well, the only thing I could share is that in our division, the End-of-Life Nursing Education Consortium project, which I included on my slide presentation today, has 8 modules, and one of them is communication. Right now, there is no sort of standardized undergraduate communication training program, but the work in LNEC is leading towards those efforts. They are now going to be developing an undergraduate nursing curriculum that's going to be tested online in 4 states in the upper Midwest through support from the Cambia Foundation. And as far as I know, that's the first efforts towards any sort of standardized curriculum at the undergraduate level.
The Macy Foundation has funded a number of initiatives. So at the University of Pittsburgh, there was a course that nurses and medical students did together where they took care of patients in long-term care, and there are a number of those kinds of programs around the country. One of the issues is that it's unclear whether the metrics that they're using to measure success is how well the professions get along and understand what each other do versus how well they give consistent stories and give the same information to patients. Most of the work has been on how well the professions work together rather than do the professions walk together in caring for patients in the way that Owen described.
I can tell you as a medical ethicist and also teaching nursing, one of the things that we need to move away from is always teaching doctors and nurses how to break bad news. If anything comes out of this, we should know that we have conversations that are difficult conversations about chronic disease, and that maybe needs to be the area that we move to in our curriculum that no one seems to be comfortable with having because we just haven't taught them that. We taught them how to say, you're dying, and that's it. I think Dr. Alvarin, you have a question?
Yes, Wilma Alvarado, Little Roundtable member. Thank you very much, and this question is for all of y'all. We've heard regarding the linguistic and cultural changes that are happening or proposed to be happening, and from the presentations, my sense is that we've directed a lot of it regarding adult care and regarding palliative care. What considerations have been made regarding palliative care in pediatrics? Because when that caretaker is the parent or a legal guardian, that becomes a little bit of a different equation. So I'd like to hear some thoughts on that.
So there are a number of flowers that are growing in that field. There's a program that Renee Boss, who's at Hopkins, has developed to train neonatologists to talk to parents about their critically ill child. Ann Thompson, who's at the University of Pittsburgh, has developed a program for pediatric intensivists. There's a program starting at the University of Indiana teaching pediatric oncologists how to have conversations with parents and children. So again, I think we're in the sort of flowering phase, and there's a lot of interest. We've taught a lot of pediatricians to become teachers of using simulated patients and talking about emotions. So Vital Talk has a whole group of people who are being supported by foundations like the Cambria Foundation to begin to do that work in pediatrics.
I'll just echo the incredible need for communication training amongst pediatrics teams. Again, as we begin to forge new elements or new areas of curriculums, and I look at the LNEC model as an example of starting with a core and then breaking into different subspecialties, I see that communication training amongst providers will have to pretty much take that same trajectory as we begin to identify specialized niches and needs in different areas.
Yes.
Cindy Brock from the Agency for Healthcare Research and Quality. And we've been talking a lot about culture change, which got me very excited when Tom opened with that, Bob opened with that. And yet both of you have spoken about somewhat standalone interventions to intervene with specific clinicians. And so that, on the face of it, doesn't sound to me like a recipe for culture change. So I'd like you to, one, talk to me about whether or not you've had experience in trying to kind of turn around an institution or system through these techniques, in addition to scaling sustainability, which you've sort of alluded to, and talk a little bit about the other things that have to be in place. So Bob, you sort of mentioned, well, you know, if you send them back, if they don't get any bennies for this good behavior, you know, what does that look like as you start to try and move that culture shift along?
Sure. You want a lot in 15 minutes, man. I
Everybody
know.
on the
I mean,
round table will tell you that.
So one of the job that they pay me for is to be the chief medical officer for palliative care for the UPMC health system, which is a very large health system in Pittsburgh, which is that city 6 hours west of Philadelphia. And there we've begun to measure. So I now can tell you at each of our hospitals how many seriously ill patients they are. And we came up with criteria that all the subspecialists, everybody agreed. So I can tell you how many there are, and then now I can begin to tell you how many of them have had a documented discussion about goals of care. So we've begun to develop metrics that I can feed back to not only the chief medical officer at each hospital, but the head of each service line. See, I can even talk like an administrator, the head of each service line. So I can go to the oncologist and say, you have this many patients with metastatic cancer who are progressed through first-line chemotherapy. This is how many have had goals of care conversations. Second, we are starting this year with having one-day courses for practicing clinicians, not fellows. We already have courses for fellows. And every intensivist, every oncologist, every hospitalist, every cardiologist who works in the cardiac coronary care unit are going to go, all have agreed in principle, their bosses have agreed that they will take a one-day course with simulated patients to talk about goals of care. My next move is to say that no medical student or intern should have this conversation. That is, we don't let in our hospital medical students or interns put in Swan-Ganz catheters. If you talk to any intensivist, it's harder to have a goals of care conversation than it is to put in a Swan-Ganz catheter. So why should we let the medical students or the interns in the middle of the night have these conversations that we know they're not well trained to have? Wendy Anderson just did a study at UCSF that showed no difference from James Tulsky's study 25 years earlier. So we're beginning to develop metrics. We have training that's developed. We have done an enormous amount of IT work so that they only document it in one place, which means that I can measure it easily. We're beginning to set up in the hospital those systems. What's probably more important, though, is that we've begun to develop home care and ambulatory-based programs. Because, look, the bottom line is once you're in the hospital, you've already, the horse has left whatever the horse leaves. And it's so hard not to get people to spend money because the defaults in the hospital are all to do more. That's just what the hospital's for. We need to begin to get our health system to build places other than nursing homes, because nursing homes have a kind of reputation that's another culture change, where people can go, where they can get their symptoms treated so that they don't go into the black hole of hospitals. And we're beginning to talk with our healthcare system about that. Can I tell you that it doesn't matter if I do it or not, because there are for-profit companies that are marketing this like crazy to healthcare systems, like Aspire, for example. This is the new big move as the whole healthcare system changes, is how are you going to take big health systems like mine, which has made money by doing more and get them to do better?
I think it's a great question to be thinking about how to initiate organizational change around the idea of communication training. We have the first National Nurse Communication Training Program. It's the first, and this is 2015. Nurses have had so little in terms of resources that our audiences, when they come, they are so happy to be there, but they are also participants who are nurses who are already recognized in their institution as being a leader in communication training, in having excellent communication skills, as being somebody who's going to be kind of the pot stirrer and initiate some change. And so because this is a research project, we wanted to make sure that we tracked that. The primary goal of our training course is that our hope is that we would have participants leave with improved communication skills, that they have the ability to go back and train others at their institution, and also that they would implement some sort of organizational change. So in order to come to our course, they have to fill out a competitive application and identify 3 goals that they will do once they leave the course and go back to their institution. And then as part of keeping track and evaluating that communication training course, we follow up with them at 6 months and 12 months and ask them, what have they done with the communication training? How many people have they trained? What disciplines have they trained? What systems have they implemented? As part of our comfort curriculum, we provide them with supplemental resources to initiate that change. So we have gone through all of the research and communication training tools, and we provide recommendations and the tools for specific decision aids that are out there, question prompt lists that have been effective or that can be addressed, specific tools to measure and evaluate communication after they've gone out and trained a group of providers. So we're really focusing on the processes of communication in addition to just creating and improving individual skills. It has to be a priority if we're going to push this further.
Michael?
Hi, thank you for talking about culture change and for pushing that conversation forward. Both of you a little bit spent your time about things in your organizations, which is awesome, but I want to just give you an opportunity to be the president of the universe for a moment and say, if you want to go beyond that, because I think this change has to happen in a broader cultural context, not just, one place at a time. If you have the opportunity, what kinds of things, where do you think there would be good levers for culture change? Kind of, because the nice parallels here between the health literacy message and the palliative care is going to be communication and in a lot. So that, where do you want to push, and how's that going to happen?
So I guess where I want to push is is community and public education. I mean, I think there is way too much faith and belief that medicine and science can fix everything that is wrong with you. And if it can't fix it now, there is a mouse somewhere that will teach you how to fix it tomorrow. And I think that what I love about the sort of work that's coming from the Boston group is not only the communication work that's inward facing, but the amount of outward facing work that they're doing with the patients and the families who are coming in for those conversations, the fact that they get a copy of advanced directive, the fact that they get told there's an advanced directive. And I think the real issue for us, if we're going to make this stick so that medicine just doesn't eat palliative care like it's eaten medical ethics, like it's eaten medical humanities, like it's eaten medical sociology, this is what happens when you're really old, you've seen all this, is that we need to train the patients to be and their caregivers to say, we want something different from the healthcare system because we can't have what they keep promising us, which is the next miracles right around the table. And that I think that one of the things that CAPC has worked really hard on is this outward facing public education. And that's what, we need our newspapers to do a better job. We need our science reporters to do a better job. And we need to have a much better an organized campaign to get them to stop writing about the best article that came out as an abstract in ASCO.
I'd also add that the topics and scope of communication training need to be much broader. I'd like to see a spiritual care communication training program for all healthcare providers. I'd like to see more interprofessional training provided. I'd like to see some training for family caregivers. We just finished developing a communication guide for caregivers that we'll be pilot studying this fall. And from our work with family caregivers, they all report the incredible burden of having to relay news to other family members, of the incredible burden of having to mediate family relationships amongst others, of having to try to incorporate the daughter from California in decision-making that's happening locally. So we need more attention to kind of this communication task that family caregivers take on and provide some training and support for that as well. Nurses have been recognized as kind of the key advocate for family and for taking on and helping and supporting that role. So we really see that as an initial first step in that direction.
Thank you. So thank you.
So a theme arises. Elaine, let me share some of your energy rather than the frail elderly example given to us by Rob. We can no longer teach medical students, forget specialty training, but we can no longer teach medical students as individuals, period. This was, I believe, and is the error made in the past, and we should not allow that to occur for the future. I think we will agree with that. They have to be taught as part of a healthcare team, with patients perhaps like Bev involved in that team, because they have to hear the other perspective. I think many schools are beginning to think about that. But this is a team sport. It really is a team sport. So when we talk about standardized patients, simulated patients, tapes, audiovisuals, true, they're very necessary, but not to be fed back to the individual physician or individual. It should be fed back to the team. Group therapy, if you will. I mean, that may be group therapy, but it will give good feedback so that when we speak about the real challenges, whether they're cultural, whether they're ethnic, the real opportunity to those challenges, it would seem to me, is to address this with the team and not with the individual. Now, again, you do know that there are medical schools who are doing exactly that, and I think they'll be more successful with their physicians. Forget the specialty training. It'll occur in the specialty training also. But as you move education to house staff, it has to begin at the medical school level. So let's tell the AAMC exactly what we're thinking. I think that would be terrific. Okay, so Renee and Robert and Elaine, this was really a wonderful panel. We really appreciate that. Even though it was pre-lunch, it was a very good panel. We'll now break for lunch. Roundtable members and speakers will meet in room 101. For others, there is a cafeteria on the third floor if you would like to do that, or if you'd like to stretch your legs and go outside. I'm sure there's some restaurants or whatever that will allow you to spend your lunch hour there. Please be sure to return on time, because we will start exactly at 1 o'clock, because we have a very robust program for the afternoon. Thank you all for your participation, and thank you all for your questions.